talking about von Hippel-Lindau disease and retinocapillary hemangioblastomas.
So thank you very much. I will explain something about diagnosis and the management of retinal hemangioblastoma in a bit more practical way. We have the von Hippel-Lindau disease, which is a rare genetic inheritable disease in which patients can develop multiple tumors. It is autosomal dominant, hereditary, and we have, in most patients, we have mutation in the VHL gene. And high penetrance, and over 90% of the patients will have one tumor or more at the age of 60 years old, with a prevalence of 2 to 3 patients per year, per 100,000 a year. In a clinical expression, we have hemangioblastomas, carcinomas, cystadenomas, and other benign tumors. And the tumors can arise at a number of preferred locations within the whole body. And the most important are actually the cerebellum, the spinal cord, the eyes, the pancreas, kidneys, and the adrenal glands. The location of where the tumors arise can vary between the different patients, and one individual patient can develop several tumor locations at the same time, and it cannot be prevented. So this is an overview of the amount of the percentage of the locations, and we see actually in 25 to 60% of the patients we can see the retinal hemangioblastoma. So we have some diagnostic criteria for whether it is in the case of a familial form or not a familial form. So if there is a positive family, VHL family member, then there should be a retinal hemangioblastoma, either CNS hemangioblastoma or any visceral lesion. Or if there is no VHL family member, then the patient should have 2 or more retinal hemangioblastomas, 2 or more CNS hemangioblastomas, 1 retinal and 1 CNS hemangioblastoma, plus a visceral lesion. And then we may have, we can distinguish them, we can put patients into different categories. We have 2 main categories of VHL, the families without pheochromocytoma, the type 1, and the families with the kidney disease. The type 1 patients have a retinal and central nervous system hemangioblastomas, the renal cell carcinomas, and the pancreatic tumors and cysts. And type 2, which is approximately 7 to 20% of the cases, so there's luckily a minority, can be divided into different subtypes, where we have the type 2A and the 2B, which have the retinal lesions, and the type 2C has only the kidney lesions. So if we look at the VHL in the different organ systems, then we see that the retinal lesions are really in the majority of the patients, almost 60%. And then we have the cerebellar hemangioblastoma, which is, of course, life-threatening eventually, the spinal cord lesions. If we look at numbers, all the patients, is about 50% of the patients have only one feature. So in the most patients, it will be a combination of different tumors. So, and there have been some studies where they looked at mutation analysis, and they showed that there is a correlation of the phenotype with the genotype, but also the age of the onset. So for the retinal lesions, we can see them at a very early age. So the ophthalmologist might be the first one to diagnose the patient with the lesion, and he sees the lesion and has to refer the patient correctly to preferably a clinical geneticist. So there we have some screening advice, and every country has its own. But in general, if we look in Europe, then we see in the majority of the patients we see retinal hemangiomas. So screening is then a multidisciplinary approach. As they have a lot of organ systems affected, the annual for the screening has to be coordinated by someone. And in the Netherlands, in most cases, it will be the endocrinologist who does who coordinates the screening and sees to that the patient has the screenings. And in some other countries, it might be the clinical geneticist, but it can differ throughout the countries. For the screening in general, the recommendation for the eyes is that there is an annual screening from the age of from very young age. And in the Netherlands, we are now around 5 years old, but the advice might be that we start at birth with the screening. So then we get back to the clinical features, because as an ophthalmologist, we can see the tumors. So that is the easy thing. You dilate the patient, you see a feature. And it's actually a benign retinal tumor with a red-orange appearance. We can see with or without subretinal fluid. We can have some exudation. We can have retinal detachment, vitreous fibrosis, and dependent on where the subretinal fluid or the attraction is, patient can have a poor visual acuity. So the location is very important, and we can divide the patient into a juxtapapillary type of the tumors into a juxtapapillary type, but also the peripheral types, and the most common are the peripheral types. So, and if we look at the hereditary component, also what's important to know is that also the sporadic retinal hemangioblastoma can have a mutation in the VHL gene. And the thing is that we have there are some publications that the sporadic hemangioblastoma may arise. They will arise from 2 separate somatic mutations which inactivate both alleles of the VHL. Whereas the von Hippel-Lindau, the type A, will inherit an defective allele, which is and an additional mutation is required for the disease. So in 24% of the cases, there can be a spontaneous mutation when there is no previously affected family member, and the inheritance is in the next generations will then take place in an autosomal dominant manner. And for the most hereditary family cancer syndromes, it might involve 1 or 2 specific tumor types, and the patients with the VHL have an increased risk of various types of benign and malignant tumors. So as a retinal hemangioblastoma is frequently the first manifestation of the disease, and together with the CNS, they are actually the most early clinical findings which might improve the general outcomes for the patients. So early detection is very important for improving the visual outcome for the patient, as the treatment is aimed at the ablation of the hemangioblastoma. You can use various techniques, and I will get into it more later on. So how do we manage these patients? We have to image them, and generally it is good to do fundus photography. We can do fluorescein angiography, OCTs, and we do not need aspiration biopsies, as they can massively bleed when you biopsy them. Here we have several patients. The middle one in the left is a typical one, but we can also have patients with really, really small lesions. Just like in the middle one, on the bottom is a really small treated lesion. And the 2 ones on the right are actually from 1 patient. What we see on fluorescein angiography is early fluorescence in the arterial phase, and in the venous phase there is still a very bright tumor. It drains fast, and we have late leakage. With OCT, it's mostly an anatomical view, and the retina is elevated by the tumor, and we can see an outer retina thickening. As you go over to the treatment for the juxtapapillary hemangioblastoma, as it's so closest to the optic nerve, in most patients we will just observe it if there is no visual deterioration. And if there is, then we can give the patient photodynamic treatment, and in some selected cases, laser photocoagulation might be an option. For the peripheral hemangioblastomas, if there is no visual deterioration, you might observe it, but it's easier to treat small lesions than large lesions, so I would advise laser photocoagulation. And in some cases, cryotherapy, resection has been described, but also for the larger lesion, a plaque radiotherapy. So a few years ago, we did an overview, a review on all the treatments for the peripheral retinal hemangioblastoma. And then if we classify tumors from up to 1 diameter, disc diameter, or up to 3 disc diameters, laser might be an option. And that's what's eventually described in the literature. Cryotherapy has been described, PLEX has been described, vitretinal surgery, but also PDT, and all treatment options have their own complications. So in a retinal hemangioblastoma, the decision for management is actually quite complex. It depends on the location and it depends on the location of your tumor. So for small asymptomatic retinal hemangioblastoma, which are near the fovea or the optic disc, observation might be an option. Laser photocoagulation is definitely an option for the small lesions, cryotherapy for the medium, photodynamic therapy also for the medium, plaque radiotherapy and resection can be options for the larger lesions, and whenever there is cystoid macular edema, anti-VEGF will definitely help. If we have patients with multifocal extensive lesions, then sunitinib has been tried. We have tried it also in some patients, and we really see a regression of the hemangioblastoma, but eventually they will just be more active. Belzutifan is described for the kidney tumors. It works very well, and also in these studies, the eye lesions decreased and became less active. So it would be very nice if we have it available in Europe for the multifocal extensive lesions. However, at the moment, there is no FDA approval for eye-only treatment. Thank you.
So I think we will move on, Emin, because we are a bit behind time, but there are definitely interesting questions, I'm sure. At least